it's me, Dr. Eman Moin here. Those who are new to my channel, let me introduce myself to them. I'm Dr. Eman Moin. I have completed my FCPS MRCOG and EBCOG exams all on the very first attempt, and I'm here to help you and guide you to complete your examinations and to go through these tough exams with confidence and complete them in your very first or the next attempt. If you find these videos helpful, please like, share and subscribe. Today we will be talking about the management of thyroid disorders in pregnancy. It is a new green top guideline number 76. Before going into details of this guideline, we will talk a little bit about the physiology of the thyroid gland. So what are the important things that are required for thyroid gland to work properly and to have a euthyroidism, not to have any hypo or hyperthyroidism or any disease of the thyroid? So there are a few things. One is the raw material, that is the iodine that is used by the gland. That is the iodine we eat in our diet. The thyroid gland pulls the iodine into the cells via sodium iodide transporter. So once the thyroid is activated and it is pulling the raw material, that is the iodine, into the gland, then next what happens? There is a protein we call thyroglobulin. The thyroid gland makes a big protein called thyroglobulin. It is consider it as a rack that iodine will stick onto. Okay, so one is the iodine, the other is the thyroglobulin protein. But who will help combining these two things, that is attaching the iodine to the thyroglobulin? So this is a key enzyme which is the thyroid peroxidase. Thyroid peroxidase will do three important jobs. It will oxidize the iodide to make it iodine, so it is usable. Attaches the iodine to the tyrosine residues on the thyroglobulin, which we call organification. So once the iodine is available and the thyroid peroxidase is not working, still the gland is not working properly. So for the proper function of the gland, iodine should be there, thyroid peroxidase should be working, and there should be a protein called thyroglobulin. Now once it is oxidized and it is in the usable form, now tyrosine residues are attached. It is attached to the tyrosine residues on the thyroglobulin. One iodine we call monoiodotyrosine. If one is attached to the tyrosine, these are present on the thyroglobulin. Okay, when two iodine attaches, that is called diiodotyrosine, and when the coupling of the iodotyrosines occur together to make a hormone, then we call it T3 and T4. Okay, so once this hormone is formed, it is stored in the gland in a colloid, and when the body needs it, it is the stimulation is by TSH, and then it is released in the blood. So what all this physiology mean? If the iodine is lacking, then what will happen? If the iodine is lacking, so the gland cannot make the hormones. Okay, if the thyroid peroxidase is blocked, it is damaged. This means that it cannot work. There will be low thyroid hormone and hypothyroidism. So sometimes it could be damaged or blocked, but if the immune system make the antibodies against the thyroid peroxidase, we call anti-thyroid peroxidase antibodies. That is why the thyroid peroxidase enzyme is really important. When in autoimmune diseases, anti-thyroid peroxidase antibodies are formed, it attacks and inflames the thyroid. In classic disease, it is called Hashimoto thyroiditis, most common cause of hypothyroidism. Over the time, the gland is destroyed and there is permanent underactive thyroid. Okay, so how you differentiate it from the Graves' disease? Graves' disease, it is hyperthyroidism. Antithyroid peroxidase may be present in the Graves' disease as well, but the main issue there is not the antithyroid peroxidase antibodies. They have a specific kind of TSH receptor antibodies, and they stimulate the gland. Okay, they stimulate the gland like crazy. I hope I'm clear up till now. This is just a brief introduction about the physiology and how it is worked. Now we will go into details of the guideline, okay? First, we have discussed about the general physiology of the gland, but now we will discuss it in relation to the pregnancy. So, dynamic in the thyroid gland changes during the pregnancy. Like any other thing, there is an increased demand for the thyroid hormones during the pregnancy. That is approximately 50%. This is an important figure from the guideline, important for the MRCOG candidates appearing in the theory and FCPS also. So requirement for the iodine is increased, and there should be absence of the thyroid disease. When the adequate iodine is present, there is no hypo and hyperthyroidism in a woman or subclinical hypothyroidism, then she can tolerate this increased demand of the iodine very well and she can cope up with the pregnancy. But if already the demand is increased in the pregnancy by 50%, and if there is iodine deficiency, the disease can be overt. Like if it is subclinical before the pregnancy, it would be evident in the pregnancy. Because of this iodine deficiency that was not previously known during the pregnancy, because of the increased demand of the body, it would be evident and shown that there is iodine deficiency in the body. And if there is sometimes subclinical hypothyroidism become overt during the pregnancy because of the increased demand by the gland, increased demand by the body for the thyroid hormone. So how these changes occur? Actually, when there is an increase in the estrogen during the pregnancy, it causes increase in the thyroxine binding globulin, and it peaks at around 18 to 20 weeks. So when the thyroid binding globulin is increasing in amount, it means that it is sticking to all the free thyroid that is available. That's why the free thyroid hormones, that is the T3 and T4, reduces in the body. So to maintain the free hormone production now reaches to a new start, right? Because now the body will need more free thyroid hormone because it's the only free portion that is available to work in the body. So when thyroxine binding globulin is increased, it means that the free hormone now will be less that should be available in the body for use. So now the gland will start working more to reach or cope up with this 50% increase. Okay. So there is one other additional physiological change that is happening during the pregnancy. That is the increase in because in the pregnancy we have a HCG, increase in the human chorionic gonadotrophin hormone as well. So it is more in the first trimester. And it is also an agonist for TSH. So when there is stimulation of the TSH, there would be increase, and you can focus on this word, there is a transient increase in the free T3 and T4 and decrease in the TSH. And towards the mid gestation, it will be gradually declining and TSH is rising again. This is a separate topic which you need to be comparing it with the gestational. This is what we call gestational hyperthyroidism, and we need to differentiate it from the hyperthyroidism, that is the Graves' disease, because in the Graves' disease there would be no decline of the T3 T4 gradually, but in the gestational hyperthyroidism there would be decline. There would be decline later on after the first trimester when the HCG is reducing, and also there would be no antibodies against the TSH receptors, or that is the thyroid stimulating antibodies, not the thyroid peroxidase antibodies. So this is how you will differentiate in between two, but today now we will be focusing more on the hypothyroidism. Okay. So apart from this increase, so why this increase is required? Because there is increased clearance, increase in the GFR. That's why the maternal thyroid synthesis is increased. Iodine is thyroid hormone is required basically. Up to 12 weeks of the pregnancy, the fetus is dependent upon the maternal iodine or the thyroid hormone, because the fetal gland has not yet started producing its own thyroid. It is important, iodine is important for the synthesis of the gland. It is important because it is stored in the placenta as well, and it is required for the breast milk production as well. So fetal thyroid iodine uptake starts by 10 to 12 weeks, and the hormone production begins around 18 to 22 weeks, and it is really important for the neurodevelopment of the baby, especially in the first half of the gestation. Okay, in the first half of the gestation. And maternal T4 crosses the placenta. It is really important before the fetal thyroid maturation. So why? Because the fetus has not produced its own, not yet started producing its own thyroid hormone. So that's why it is dependent upon the maternal thyroid. I hope I am clear up till this point. So during the pregnancy, you have to use some certain limits for the free T4, T3 and TSH. According to the Green Top guideline, you should adopt a TSH of the upper limit of 4.0. Okay, it should be maintained like this in the pregnancy. In the Green Top guideline, in Appendix 4, the trimester specific values for the TSH and free T3 and T4 is also given. Now I need your attention specifically for this part of the guideline. This is a very easy guideline, but you need to pay attention. Okay, so definition of the thyroid, definition by thyroid functioning test. Overt hypothyroidism. Overt means that it is already evident. So overt means TSH would be increased, free T4 would be decreased. Because it is hypothyroidism, the gland is stimulated by TSH, but there is no production, and it is further stimulation. There is no negative feedback, so it is increased. In subclinical hypothyroidism, what happens? There is increase in the TSH concentration, but the free T3, T4 are normal. Okay, overt hypothyroidism makes about 0.2 to 1%, and the subclinical is 2.2 to 10%. Isolated hypothyroxemia means only the free T4 concentration would be less. Gestational transient thyrotoxicosis. In this, the TSH is suppressed and increased in the free T4 concentration. See, both the overt and the gestational, this TSH is suppressed and free T4 is increased. But how you will differentiate? Because in the gestational, this increase and decrease will resolve by the end of first trimester. Okay, and there is no presence of, or the, you can say, the absence of autoantibodies. Okay, so the next part is that this is the pregnancy upper TSH limit, that is 4. Okay, this one is 4 millionut per liter. But if you focus here, they are saying that if the woman is on the thyroid related medication, you have to use the treatment specific target rather than the diagnostic ranges. So means for diagnosis in pregnancy, the upper limit of TSH is 4. But for treatment, okay, you should keep the TSH below 2.5. So that's why in the guideline they say if a woman is already on medication like levothyroxine or antithyroid drugs, then you should use the treatment specific targets rather than the diagnostic one. Okay, now let's summarize why iodine is important. Iodine is essential for thyroid hormone synthesis. In pregnancy, thyroid hormone is crucial for the fetal brain and neurodevelopment, specifically in the first trimester before the fetus produces its own thyroid hormones. Both the iodine deficiency and excess can cause maternal and fetal thyroid dysfunction. Now, if iodine is important this much, what should we do? We should take the iodine daily to 200 to 250 microgram. Okay, this is all these facts and figures which I am telling you. This is from the Green Top guideline itself. Okay, So, in pregnancy, those who are planning the pregnancy or the breastfeeding, all of them require 200 to 250 microgram per day. It could be achieved through dietary sources like milk, yogurt, eggs, and fish, and it could be achieved through a prenatal supplements containing 150 microgram of the potassium iodide. Do not take the multiple iodine containing supplement at once, because there is the risk of excess, and that is not good. According to the guideline, we should avoid the sustained intake of more than 500 microgram, because it may cause the maternal and fetal thyroid dysfunction. So we want it to be euthyroid, not the hypothyroid and not the hyperthyroid. Now, what are the timings for the supplementation? So we discussed already that we need to give these thyroid supplements to those who are preconception, just like folic acid. And also we need to give it to women who are pregnant and those who are breastfeeding. So these are the three main categories of the women requiring iodine. So when to start it? Ideally, it should be 3 months before the conception. If not, then start as soon as possible if the pregnancy is confirmed. Early supplementation has a greater benefit for the maternal thyroid function, because possibly fetal neurodevelopment is dependent upon the maternal thyroid hormones during the first 3 months of the pregnancy. So that's why it is important to start preconception. Now we have discussed about what is the importance of the thyroid gland during the pregnancy, how the hormone synthesis is different, how the iodine deficiency can affect the pregnancy, how the iodine or the thyroid dysfunction can affect the growing fetus and can affect the neurodevelopmental delay of the baby. And the baby is dependent upon the maternal thyroid during the first 3 months mostly, and baby start producing its own thyroid hormone by 18 to 20 weeks. Now, after we have discussed this, then we discussed about the dietary sources. If not dietary, then from the outside in the form of prenatal vitamins. What is the requirement? 200 to 250 microgram is the requirement. Potassium iodide we can give 150 milligram. And so the potassium iodide, I want to correct, we give 150 microgram. We need to start it before 3 months before the conception, or at the time of the pregnancy, as soon as the pregnancy is confirmed. And then testing and monitoring is really important. So sometimes they debate about whether the universal testing should be done during the pregnancy, because it is more than a lot of female in the UK are iodine deficient. So there is a debate. Some say that it should be done, some say it should not be done. There should not be a universal testing. So the consensus for up to 50% of the women are iodine deficient in the first trimester in UK. So there is no consensus upon whether all women. So for all women, no screening for the iodine deficiency at the start of the pregnancy. But there are some specific women with few risk factors. For those women, if you get in your question, Viva question, or in a clinical case scenario, if you see those risk factors in a lady, then you definitely need to do the testing of the thyroid function test at the booking, or in the next pregnancy at the booking. Okay. So pre-pregnancy supplementation in iodine deficient population is required for better maternal thyroid function and potential benefits. Now, universal testing is not recommended. Why not? Because overt hypothyroidism is only a small percentage of the women, and untreated overt hypothyroidism can lead to miscarriage, preterm birth, impaired child development, and often is asymptomatic. Okay, the subclinical they are talking about. Easily diagnosed with the thyroid function test, and it can easily be treated with the levothyroxine. But the problem is that if we do universal testing, overt hypothyroidism is only a tiny fraction of the positive that we have already discussed. Majority would be gestational transient thyrotoxicosis, subclinical, and isolated hypothyroxemia. So for this reason, treatment benefit in the subclinical and isolated is not proven, and cause effectiveness remains uncertain. So in simple word, this means that universal testing is not recommended because only a small amount of the women that are having the overt hypothyroidism require treatment. Not require treatment. There is a small amount of the women who are having overt hypothyroidism. These women require treatment, but a large majority of the women that would be diagnosed are either subclinical and they are isolated hypothyroxemia. So in subclinical, in certain women, they will not be, for certain women, they will not require thyroxine during the pregnancy or when this condition is diagnosed. We will be talking about the subclinical hypothyroidism in a while so that the concept is more clear. We have three hypothyroidisms, right? We have isolated hypothyroxemia, we have overt, and we have subclinical. So overt hypothyroidism, subclinical hypothyroidism, and isolated hypothyroxemia. This will definitely require treatment with levothyroxine. This will not require treatment. In some conditions, subclinical, when the TSH level is more than 10, we call it severe subclinical hypothyroidism. This severe subclinical, according to the guideline, treatment should be offered. But moderate, that is between less than 10 milliunit per liter, treatment is considered. Okay, I hope. And this for isolated, no treatment required. That's why they say that here we consider the treatment, because this is not all would be severe subclinical hypothyroidism. So there no treatment is required. In subclinical hypothyroidism, offer the treatment if it is severe form. Consider the treatment if it is the moderate form. That is, the TSH is less than 10. So for this reason, they said that the overt hypothyroidism is only a small proportion of the women. So why to do the universal testing? Those women who are at risk of hypothyroidism, we will do testing for them. Okay, so no universal, but selected cases do TFTs and screen for the thyroid disease. Okay. So the conclusion is that the universal testing is not recommended. These are the conditions. It should trigger the thyroid functional testing in the early pregnancy. This is really important. So any woman, if you get in your MCQs, in an exam questions, in the scenarios, vivas, structured discussion, they can ask you that a woman, so any of the women who have these risk factors, you have to say in the booking investigation the thyroid function test. We will start from here. Previous late pregnancy loss, that is stillbirth and second trimester miscarriages. Autoimmune condition like type 1 diabetes, SLE, antirotella, antiphospholipid. I'll be discussing why it is important to test in these women. Okay. In IUFD and miscarriage, thyroid is related to these conditions. So that's why we do testing in any woman with such a history. We do testing in the next pregnancy, at the booking or early pregnancy. Now you have to divide it into the 4 causes like this. Okay. So if the previous thyroid surgery has been done, if there was a thyroid nodule or goiter, this woman is likely to be on the risk of developing some thyroid condition during the pregnancy. Autoimmune conditions like previously overt or subclinical thyroid, previous thyroiditis, and known thyroid peroxidase antibodies. For these women, you will do at booking and at 20 weeks, because there is a risk of conversion to, they are at a risk of development of hypothyroidism. That's why. Okay. And cardiac arrhythmia, significant weight loss, enlarging thyroid, and previous neck irradiation if on imidrone and lithium, or previous radio iodine ablation. So in the history, this is I'm telling for the clinical candidates, drug history is important. If she is on lithium, imidrone, then you have to tell the woman that she needs thyroid function test at booking. Okay, here I have explained it again because it was given in a tabulated form in the green top guidelines and it as well as in the paragraph form. So whenever you are testing these women, ideally by the first trimester, the one we discussed in the table, so you should do the TSH and both free T4 together. It's not that you do TSH now and on the next visit you do both, you should do together. So there are three broad categories: woman with a past thyroid disease or risk of thyroid damage, like she had previous radioiodine irradiation on thyroid disrupted drug, any previous postpartum thyroiditis, because with the passage of time these women with the postpartum thyroiditis are at increased risk of hypothyroidism over the years. Women with an autoimmune disease, it is important because 16% will have overt hypothyroidism in pregnancy, those who have type 1 diabetes. With SLE, 11% risk of thyroid disease. Increase in the adverse outcome, that is the preterm birth, is 65% versus 18%. When there is a combination of a thyroid disease plus SLE, then the risk of preterm birth is increased to 65% from a background risk of 18% with SLE only. Enteroantigen bodies, if positive, risk of the heart block is worsened if the thyroid gland function coexist. So let's suppose if you have a lady with a pregnancy and she's a known diabetic and she comes for the booking visit, so you will be doing the type 1 diabetic, okay, not for the type 2 diabetes or GDM. Then you have to do at the booking the thyroid function test as well. If she wants for the explanation, or if examiner or anyone is wanting explanation, you can explain to them that there is a risk of 16% that she can have some thyroid problems during her pregnancy. If a woman is having SLE, you get an SLE scenario and you want to go for a booking investigation, you should add the thyroid function test because she's at a risk of preterm labor 65% more than the background risk of 18. And whenever she has enteroantigen with SLE positive, the risk of fetal heart block is worsened. So now what is the obstetric history? Women with the adverse obstetric history, like previous late miscarriage or stillbirth, in the green top guideline IUFT they have added that the woman who have IUFT in the next pregnancy, they will have a thyroid function test at the booking, and here they have also added the stillbirth here because it is linked to the subclinical and the overt hypothyroidism. And green top guideline 55 recommends the TFTs after stillbirth. Extend this to the early testing in the next pregnancy, right? Now we will be discussing about the hypothyroidism and the subclinical in the pregnancy. Overt hypothyroidism, we have discussed that there is a reduced free T4 and a high TSH. If this is untreated, this should be on your fingertips. It can lead to the miscarriage, preterm birth and low birth weight. Neurodevelopmental defects should be there in the children, that is the IQ drop, and this is proportional to the maternal TSH elevation. Okay, the more the TSH is high, more the severe the hypothyroidism is, and it is affecting the IQ of the child. So we have the goal of the treatment. We discussed the upper limit during the pregnancy is 4, and the treatment goal is that we should keep the TSH less than or equal to 2.5 milliunit per liter in the first trimester. We will be using the levothyroxine. Okay, that is the levothyroxine T4. There are other types of the thyroid hormones available, but we will not use that. The levothyroxine is the only one that can be used. The other types are unsafe and they do not cross the placenta. So now you should focus on these things. If you diagnose a newly, if like overt hypothyroidism is diagnosed during the pregnancy, then you need to start the 1.6 microgram per kg per day of the levothyroxine. Okay, so if you have overt hypothyroidism that is diagnosed during pregnancy, focus on these doses, but later on I have make a table for you. It will help you understand all this green top guideline related to the hypothyroidism in one go. So bear with me for some time because you need to stay focused, right? So this is newly diagnosed. You have to start 1.6 microgram per kg. You have to adjust it every 4 to 6 weeks until 20 weeks, and then once again at 28 weeks. So means you have to check the thyroid function test regularly every 4 to 6 weeks until 20, and then once again at 28 weeks. The target, it should be less than 2.5. Okay. Now there is subclinical hypothyroidism. TSH is above the pregnancy limit with a normal T4. Severe is a kind in which the TSH is more than 10. What are the risks? It's not that this subclinical is not comes with any risk for the pregnancy. There is preeclampsia, there is preterm birth, there is small for gestational age, pregnancy loss, abruption, breach, and neurodevelopmental effects in the offspring. Who are at high risk of progression to the overt hypothyroidism? Those women who are having subclinical but they have thyroid peroxidase antibodies positive, TSH is more than 10, previous radioiodine or hemithyroidectomy. You can focus on these things and link why subclinical can lead to the hypothyroidism later, that is the overt. Because if thyroid peroxidase antibodies are positive, it means that they are slowly and gradually destructing the gland. The gland cannot do its function properly. So at the end, it can lead to the overt hypothyroidism. If TSH is more than 10, it means that she is at risk of developing overt hypothyroidism more than any woman who has TSH less than 10. Okay, a previous radioiodine or hemithyroidectomy, it also reduces the thyroid gland properly, the functioning part of the thyroid gland. So what is our aim? For the overt thyroidism, hypothyroidism, the clear cut aim is to start the treatment. Okay, we will not wait because it is related with a lot of side effects. The neurodevelopmental delay of the baby, drop in the child IQ, miscarriage, preterm birth. So without a second thought, overt hypothyroidism is for treatment. But in subclinical hypothyroidism, whenever we have severe kind, that is the TSH is more than 10, we need to treat it always at every cost. Okay. But if it is TSH is above the range but less than 10, okay, what was the range in the pregnancy? 4. It means if it is more than 4 but less than 10, we can consider treatment. Especially consider the treatment if the thyroid peroxidase antibodies are present. Now you can see here the difference in the dose. When it was overt hypothyroidism, the suggested dose was 1.6. Now here the dose is 1 to 1.2 microgram per kg per day. So pay a close attention to these doses as well. In subclinical hypothyroidism, why we want to give the thyroxine? Because it will decrease the pregnancy loss, decrease the neonatal death, preterm, gestational hypertension, and the benefits are greatest if it is started in the first trimester. The third component is the isolated hypothyroxemia. There is low free T4 with normal TSH, but usually the most important cause is iodine deficiency. It could be a part of a exam question in MCQs as well, but it can be related to the obesity and iron deficiency. So the risks, but there is inconsistent evidence it is associated with a possible increased risk of placental abruption. So routine levothyroxine is not recommended, but you need to recheck TFTs in 4 to 6 weeks. Okay. Now we will be starting from a pre-pregnancy care. So when a woman is on overt hypothyroidism or subclinical hypothyroidism, she is planning a pregnancy. Aim for TSH is less than 2.5 preconception. If subclinical, that is the TSH is 4 to 10 and thyroid peroxidase is positive, consider starting treatment that we have already discussed. The only difference is that the woman is already on the levothyroxine. Previously, we have discussed that the woman was having overt hypothyroidism diagnosed during the pregnancy and subclinical diagnosed during the pregnancy. So when the overt is diagnosed during the pregnancy, you have to start the levothyroxine 1.6 microgram per kg per day. But if subclinical and she is on levothyroxine, you need to start her on levothyroxine, and it is diagnosed during the pregnancy, then you start from 1 to 1.2 microgram per kg. Am I clear so far? So in this way, if the third option is that if the woman is already, before the pregnancy she is diagnosed and she is on levothyroxine, whether she is subclinical or overt hypothyroidism, then you need to increase the levothyroxine dose as soon as she is pregnant by 25 to 30%. How you can do this? Either you double the dose of levothyroxine on the 2 days per week. That is, let's suppose if she is taking 50 microgram, then on Saturday and Sunday you can give her 100 microgram. Or if she's taking 25, then on 2 days per week you can double the dose on the baseline at 25 to 50 microgram depending upon the baseline. But you can start increment of the dose as well in this form. You can increase 25 microgram per day for women taking 100 or less levothyroxine, or you can add 50 microgram per day for women taking greater than 100 microgram levothyroxine. So for subclinical hypothyroidism, it prevents the first trimester hypothyroidism. Why it is important to treat these women? Because requirement increases in the pregnancy and we need to cope up with those requirements. Okay, so now it is very important what you need to do if the hypothyroidism is diagnosed during the pregnancy, subclinical is diagnosed during the pregnancy, or woman is already taking the levothyroxine and she is a known case of overt or subclinical hypothyroidism. So for women during the pregnancy, we have to monitor the TSH every 4 to 6 weeks until 20 weeks and then once at 28 weeks. Any woman on the treatment, the target is to keep the TSH less than 2.5. We do not want to do the over treatment as well, because if we give levothyroxine from the outside, it will cause high maternal free T4. It is linked to low birth weight, autism, ADHD, and child IQ would be reduced. If there is nausea and vomiting and the woman cannot take the levothyroxine, or if the effect is not that, if she's having nausea, she's vomiting, then we can adjust the timing or split the dose. If unable to tolerate, then consider IV option with endocrinology input. This is very important point. Now when the woman has delivered, those who were already on the levothyroxine pre-pregnancy, they need to revert to the pre-pregnancy dose within 2 weeks postpartum. Okay, within 2 weeks postpartum. And then recheck TSH at 6 to 8 weeks. But those who have started levothyroxine in the pregnancy, stop at birth and recheck TFTs at 6 weeks postpartum. Because those women who have positive thyroid peroxidase, they are at risk of postpartum thyroiditis. Okay. Now some examples. Overt hypothyroidism, always treat. Aim is TSH less than 2.5. Subclinical hypothyroidism, treat if TSH is more than 10. Consider if thyroid peroxidase is positive and TSH is between 4 to 10. Isolated, do not routinely require the treatment. Pre-pregnancy, aim TSH less than 2.5 if she's already on treatment. Okay, if she's already on treatment, this is just the limit for the treatment, the upper limit for the treatment. Counsel on self-increasing. Pregnancy monitor every 4 to 6 weeks until 20 weeks and then once at 28 weeks. Postpartum, revert or stop levothyroxine depending upon the baseline. So if she is already taking the levothyroxine before the pregnancy, then she needs to revert back to the pre-pregnancy dosage. But if she started during the pregnancy, then you need to stop. And then again, should all women be tested? Routine thyroid peroxidase testing is not recommended. Why? Because no intervention improves the outcome in euthyroid woman. If the woman is euthyroid, then there is no need. What if the woman is already known to be a thyroid positive but euthyroid? They should be offered TSH testing and free T4 testing in first trimester and again at 20 weeks. So all pregnant women do not require testing. There is testing for the specified group that we discussed previously. Whenever there is a positive thyroid peroxidase antibodies in a woman, she should have a repeat testing again at booking and at 20 weeks, because they are at risk of developing the overt or subclinical hypothyroidism. Okay. Somehow you can get a question also, if a woman is euthyroid and just thyroid peroxidase antibody positive, should she receive levothyroxine? The answer is no. Even if a woman is euthyroid and thyroid peroxidase is positive, there is a risk of miscarriage and preterm birth. Okay, so for thyroid peroxidase you need to know two things. If a woman is positive having thyroid peroxidase antibodies and she's euthyroid, she doesn't need treatment, but she needs monitoring at 20 weeks and again at the booking and again at the 20 weeks. So the last few pearls: do not screen universally. If a woman is known to be thyroid antioxidase positive, antibodies positive, peroxidase, then monitor TFT's early, booking at 20 week. Do not give levothyroxine, but remember that only the positivity of the thyroid peroxidase is associated with miscarriage and preterm birth. Reassure about the baby. Thyroid peroxidase do not harm the fetal thyroid directly. So if they ask, are you thyroid woman antibodies positive, then you should say that we will monitor carefully, educate about the miscarriage, and reassure about no direct fetal harm. Now this is just a summarization. If a woman is having a hypothyroidism, it could be overt, it could be subclinical, it could be overt, subclinical, or isolated. So now you need to know that whether she is already on treatment. This is for overt. If she is already on treatment, then counsel to self-increase the dose by 25 to 30%, double the dose 2 days per week, or add on 25 to 50 microgram depending upon the baseline. If it is diagnosed during the pregnancy, then you need to start with 1.6 microgram per kg per day. Okay, and this we have already discussed, 25 microgram if she is taking 100 or less, and 50 microgram if she is taking 100 or more. Same goes for the subclinical. If she is already on treatment, you need to increase the dose, but if diagnosed during the pregnancy, you can see the difference in the dosage here, 1.6 and here 1.1 to 1.2 microgram per day. Isolated hypothyroxemia, no treatment is required. How you will monitor the thyroid in the pregnancy? Every 4 to 6 weeks until 20 weeks, and then once at 28 weeks. Now postpartum management. Postpartum management is really important. Who are already on the levothyroxine, revert to the pre-pregnancy doses within 2 weeks and recheck TSH at 6 to 8 weeks. But those who started during the pregnancy, you need to stop, but you need to check again the TFTs also. Now this is the same from the green top guideline. If overt hypothyroidism, levothyroxine replacement is really important. If subclinical and DSH is more than 10, again you give levothyroxine. If subclinical and between the upper limit and 10, diagnosis in the first trimester, strongly consider levothyroxine. Diagnosis at after the first trimester, consider levothyroxine. Isolated, no treatment is required. Monitor the thyroid function at 4 to 6 weeks interval up to 20 weeks, and then once again at 28 weeks for overt hypothyroidism. Okay, this is specifically, this monitoring is for those who are not on treatment. Okay, because they are overt hypothyroidism but they are not on treatment, then you need to monitor. If there is some derangement, then you can start. Here we can strongly consider, here we consider levothyroxine. If thyroid antioxidase is positive and there is euthyroidism, then you will do at booking thyroid peroxidase and again at 20 weeks. There is a lot of repetition I am doing, but just because so that this concept can stick to your mind. And levothyroxine treatment is not recommended. I hope when you go through the hypothyroidism part of the Green Dot guideline, it will now be very easy for you because I have already summarized everything very clearly. But since it is just I am recording this lecture, it is not an interactive. I am more happy if I am doing an interactive lecture because it gives me a sense that someone is listening and responding to me. So I think teaching is like way more better when you do it in a live sessions or when there is an interactive class instead of just recording these. So if you like, please, if it is helpful for you in any way, whether it's your clinical theories or MRCOG, because if you have the base knowledge or a background knowledge of any Green Dot guideline, you can tackle every case of hypothyroidism, whether it comes in the FCPS clinicals or whether it comes in MRCOG 3, or you get any scenarios or different EMQs in MRCOG 2. If you pay attention to these minute details, it would be easy for you to crack all these exams in your one go. Okay, if you like it, please share with your friends, subscribe to my channel, and also if you want more videos, let me know in the comments. Thank you.